You know, that weird little flutter you sometimes get, maybe a twitch in your leg, or just a strange sensation that pops up and then poof, it's gone.
Yeah, totally. Happens to everyone.
It can be a bit unsettling, though, when your body just does something unexpected. Now, imagine scaling that up, making it really intense, uncontrolled, and maybe even losing awareness.
Well, then you're moving into the territory of seizures.
Exactly. And
Yeah.
understanding how to manage those powerful, often unpredictable events brings us to a really fascinating group of medicines,
Hmm.
anticonvulsant drugs.
Yeah, that's our focus today.
For this deep dive, we've dug into a detailed lecture that outlines these medications. So our goal is to unpack how they're classified, the different ways they influence the brain's activity, and how they're actually used.
Right. Trying to get a handle on how we calm down what are essentially like electrical storms in the brain.
That's a good way to put it. So the material we looked at covers the basic ways seizures are categorized, whether they start in one spot or involve the whole brain.
Yeah, partial versus generalized. And then it gets into the major classes of anticonvulsants, grouped by their mechanism of action, how they actually work at the neuron level.
We'll also touch on specific drug examples and some key things to think about when using them.
Definitely.
So our mission for you today is to give you a clear, understandable overview of how these anticonvulsants function. We want to shed light on the complexities of managing seizures, but, without getting totally lost in the weeds.
Aiming for those aha moments where you kind of see how these drugs are trying to step in and regulate that brain activity.
Okay, so
Oh,
to kick things off,
why?
what exactly is happening in the brain during a seizure? What's the core issue?
Well, at its heart, a seizure is an episode of abnormal, excessive electrical activity in the brain. Think of it like a sudden power surge or a misfire in the brain's circuits.
Okay.
And this can show up in a huge range of ways, from those really subtle movements or sensations you mentioned earlier to much more dramatic physical changes.
And these are things you can actually see on certain tests, right?
Exactly. You can record and observe this abnormal activity using an EEG, an electroencephalogram.
And it's not just one type of electrical storm, is it? The lecture mentioned different classifications.
Precisely. The two main buckets are partial, sometimes called focal seizures, and generalized seizures.
Okay, what's the difference?
So partial seizures start in a specific spot, a focal point, within just one side, one hemisphere of the brain. And crucially, they don't always involve losing consciousness.
Ah,
Within that, you've got simple partial seizures where the person stays fully aware. Then there are complex partial seizures where awareness is altered. People might seem confused or do repetitive things, automatisms, or have behavioral changes.
hmm.
And then there's a third type called secondarily generalized seizures. These start out as focal,
In one spot.
but then they spread to involve the whole brain, leading to a loss of consciousness. Kind of evolves.
Got it. So it's about where it starts and whether it spreads. What about the generalized seizures then?
Generalized seizures involve both sides of the brain, both hemispheres, right from the beginning, and they almost always involve losing consciousness.
Okay. Are there different kinds of those too?
Oh, yes. Several types. You have tonic-clonic seizures, probably the most widely known type, sometimes called grand mal. That involves a stiffening phase, the tonic part, followed by rhythmic jerking, the clonic part.
Right.
Then you can have just tonic seizures with only the stiffening, or just clonic seizures with only the jerking. Myoclonic seizures are these really brief, almost shock-like muscle jerks.
Okay.
Atonic seizures are the opposite, a sudden, complete loss of muscle tone, which can cause falls, unfortunately.
Wow, yeah.
And finally, absent seizures, sometimes called petit mal. These are very brief, just seconds, maybe of blank staring or unresponsiveness, sometimes with little signs like eye blinking or slight twitches.
It really sounds like the way a seizure looks can tell you something about what's happening electrically in the brain. Do we usually know what causes this abnormal activity to start?
That's the big question, isn't it? And interestingly, in a lot of cases, maybe 60–70% the exact cause, the etiology, is actually unknown.
Really?
That high, yeah. But we do know some risk factors. Family history is definitely one. There's a genetic component for some people. And also any kind of damage to the brain.
Like what?
Well, things like brain tumors, significant head injuries, infections like meningitis or encephalitis, or even damage from a stroke, these can all potentially trigger epilepsy later on.
So even if we don't always know the initial spark, what's the overall strategy with anti-epileptic drugs? What are they trying to achieve?
The main goal is to stop that abnormal electrical discharge from spreading through the brain. These drugs work by making it harder for neurons to fire really rapidly and repetitively.
So damping down the storm.
Exactly, quieting things down to prevent seizures. And of course, the ideal is to do that with the fewest possible side effects.
Makes sense. Okay, so the aim is to calm those hyperactive neurons. The lecture then dives into the different ways these drugs actually achieve that. Let's talk about the first major group, drugs that block voltage-gated sodium channels. Can you break that down a bit?
Sure. What's really neat about these drugs is how they kind of selectively target the neurons that are misbehaving, the ones firing too fast. They block these specific channels called fast sodium channels.
And those are important for?
They're absolutely essential for nerve cells to generate electrical signals, the action potentials. But the key thing is how these drugs block them. They tend to bind more effectively to the sodium channels when they're in an inactive state.
Inactive state.
Yeah, it's a state the channel enters right after it's been open and needs to recover. When neurons are firing very, very quickly, like during a seizure, more of these channels are caught in that inactive state.
So the drug has more targets to hit when things are going haywire.
That's a great way to think about it. So during normal brain activity, with slower firing rates, fewer channels are inactive, meaning the drug has less effect on normal function. It's called use-dependent blockade.
Use-dependent, okay.
The more the channel's being used hyperactively, the more vulnerable it is to the drug.
That's actually quite elegant.
Yeah.
So which specific drugs work this way?
There are quite a few important ones. You've got phenytoin and its injectable form, fosphenytoin. Then there's carbamazepine and a related one, oxcarbazepine. Also sodium valproate, lamotrigine, topiramate, and zonisamide. It's a pretty major group.
Let's pick out a couple. Phenytoin, that was one of the early ones, wasn't it? But the lecture implied it's maybe not the first choice anymore. Why is that?
That's right. It was a huge step forward, but it does have some significant downsides. One big one is its pharmacokinetics, how the body handles it. It follows what's called zero-order kinetics, meaning the body's ability to break it down gets saturated easily. So even a small increase in the dose can cause a really big, unpredictable jump in the drug level in the blood. Think of like a traffic jam at a toll booth. Once capacity is reached, things back up fast.
Okay, that sounds tricky to manage.
It is, and it has a narrow therapeutic window. The gap between an effective dose and a toxic dose is small, so it often needs careful blood level monitoring. Plus, it has a list of potential side effects.
Like what?
Things like involuntary eye movements, nystagmus, problems with balance and coordination ataxia, overgrowth of the gums, which can be quite pronounced, increased hair growth, and it also carries risks in pregnancy.
And interactions.
Yes, significant interactions. It speeds up the liver enzymes that break down many other drugs, so that needs careful management too. So while effective, it requires a lot of attention.
Okay, what about carbamazepine, used for similar seizures, right?
Yes, carbamazepine is used for partial and generalized tonic-clonic seizures. And interestingly, it's also used for other things like trigeminal neuralgia, a type of nerve pain, and sometimes bipolar disorder.
Does it have similar issues to phenytoin?
It has its own set of potential side effects, similar neurological ones like dizziness, unsteadiness, also risk of rash, and it can affect sodium levels. There are also rare but serious blood disorders associated with it, and yes, it carries risks in pregnancy.
Interactions too.
It does interact with other drugs by speeding up their metabolism, and kind of uniquely, it can actually induce its own metabolism over time, meaning the dose might need adjusting.
Huh. The lecture also mentioned oxcarbazepine related to carbamazepine. Any advantages there?
Oxcarbazepine is a derivative, yeah. It works similarly, but it was designed to maybe have fewer drug interactions than carbamazepine, which can be a big plus if someone's on multiple meds.
Okay.
The risk of those serious blood issues is thought to be lower too, but on the flip side, it might have a higher risk of causing low sodium levels, hyponatremia.
Trade-offs, as always. All right, moving through the sodium channel group. Sodium valproate, or valproic acid. This one seemed interesting because it has another mechanism mentioned.
That's right. Valproate is a bit of a multitasker. It hits the sodium channels, yes, but it also boosts the activity of GABA.
GABA being the calming neurotransmitter.
Exactly, the main inhibitory one. Valproate seems to slow down GABA's breakdown. Because it works in multiple ways, it's effective against a really broad range of seizure types, partial, generalized, tonic-clonic, absent seizures. It's quite versatile. It's even used for migraine prevention.
What about its side effects?
Generally, maybe fewer of some of the neurological side effects compared to, say, phenytoin. But it has its own serious considerations. There's a risk of liver toxicity, liver failure, which is a major concern, especially if used with other antiepileptics.
Okay, that's significant.
And it's particularly problematic during pregnancy. It carries a relatively high risk of birth defects, like neural tube defects, and potentially developmental issues like autism spectrum disorder. So it's generally avoided if possible, especially in women of childbearing potential, and obviously contraindicated in liver disease.
And interactions.
It actually does the opposite of phenytoin and carbamazepine. It can inhibit the breakdown of some other drugs, potentially increasing their levels.
So many factors to juggle. Okay, one more in this group. Lamotrigine
Uh-huh.
also hits sodium channels,
Yes, lamotrigine blocks sodium channels, and it also seems to reduce the release of glutamate.
which is an excitatory neurotransmitter.
Right, the brain's main go signal. So lamotrigine kind of does both, blocks sodium channels and reduces excitation. It's used for various seizure types and also in bipolar disorder.
Any key things to watch out for with lamotrigine?
The main one everyone talks about is the risk of a skin rash. Usually it's mild, but in rare cases it can become very severe, even life-threatening Stevens-Johnson syndrome.
Wow, how do they manage that risk?
The key is starting at a very low dose and increasing it really slowly, titrating it up over weeks. This significantly reduces the risk of the severe rash. It's also generally avoided in people with liver failure.
Okay, that's a good rundown of the sodium channel blockers. The lecturer then moved to a different mechanism, drugs that inhibit T-type calcium channels. Seems like one main player here.
Yes, the classic example, and really the main one in this specific class, is ethosuximide.
What do these T-type calcium channels do?
These are specific, low-threshold calcium channels found predominantly in the thalamus. The thalamus acts like a relay station in the brain, and these channels are thought to be critical in generating the specific kind of rhythmic brain activity you see during absence seizures.
Ah, the petit mal seizures.
Exactly. So ethosuximide, by blocking these channels, is very effective specifically for simple absence seizures. It's often the drug of choice for that type, especially in kids, and it tends to be well tolerated.
But just for absence seizures.
Pretty much. It's not effective for other types like tonic-clonic seizures and might even make them worse. Side effects are usually things like GI upset, maybe some drowsiness or mood swings, and very rarely it can affect bone marrow.
So very targeted. Okay, next big category, drugs that boost GABA activity. Let's just quickly refresh. What does GABA do again?
So GABA, that's gamma-aminobutyric acid, is the brain's primary inhibitory neurotransmitter. Think of it as the main brake pedal for neuronal activity. It helps calm things down, preventing excessive firing.
Got it. So these drugs basically help GABA put the brakes on more effectively.
That's the idea. They enhance GABA's natural calming effect, making it harder for seizures to happen. And there are a few different ways they do this.
Right. The lecture broke this down. First up was directly stimulating the GABA receptor complex. Barbiturates and benzodiazepines fall here.
Exactly. Both groups work on the main GABA receptor, the GABA receptor. This receptor is linked to a channel that lets chloride ions flow into the neuron.
And chloride ions.
When negative chloride ions enter, they make the neuron less excitable, less likely to fire an action potential, so more inhibition.
How do barbiturates and benzos differ in how they affect this?
Barbiturates, like phenobarbital or primidone, seem to work by holding that chloride channel open for a longer duration once GABA binds, so more chloride gets in per opening event.
Okay. And benzodiazepines.
Benzodiazepines like clonazepam, diazepam, lorazepam, they work differently. They increase the frequency of the chloride channel opening when GABA binds, so GABA becomes more efficient at opening the channel. Same overall effect, more inhibition, but through a slightly different mechanism.
Interesting. What about phenobarbital, one of the barbiturates? Any major points there?
Sedation is a big one. It can make people quite drowsy, which often limits its practical use. It can also cause respiratory depression, especially at higher doses or if combined with other sedatives.
And interactions.
Yes, like phenytoin, it's a potent inducer of liver enzymes, so it speeds up the metabolism of many other drugs. Because of the sedation and respiratory risks, it's often avoided in young kids, the elderly, and anyone with breathing problems.
Okay. What about the benzodiazepines like diazepam and lorazepam? We hear about those a lot, especially for emergencies.
Right. They also cause sedation and can depress breathing, similar concerns, but they are absolutely vital for treating status epilepticus, that prolonged seizure emergency we'll talk more about.
So for stopping seizures quickly.
Exactly. Lorazepam or diazepam are often the first drugs given to stop a seizure that's going on too long. Clonazepam is sometimes used for longer-term seizure management as well, but again, caution is needed in people with respiratory issues.
Okay, another way to boost GABA mentioned was blocking its reuptake. Tiagabine was the example. How does that work?
So after BAGA is released into the synapse, the gap between neurons, it needs to be cleared away. One way this happens is through transporter proteins that suck it back up into the cells. Tiagabine blocks one of these transporters, called GAT1.
So it leaves more GABA hanging around in the synapse.
Precisely. More GABA stays in the gap for longer, increasing the inhibitory signal. It's mainly used as an add-on therapy for partial seizures.
Then there were the GABA mimetics, gabapentin and pregabalin. The name is a bit misleading, the lecture said.
Yeah, it is. You'd think they mimic GABA, acting on GABA receptors because they look structurally similar. But they actually don't.
So how do they work?
Their main anti-seizure mechanism seems to be blocking certain types of voltage-gated calcium channels. These channels are involved in releasing neurotransmitters at the synapse.
Ah, okay. Different mechanism entirely. What are they used for?
They're used as add-on therapy for partial seizures, but they're perhaps even more widely used now for treating neuropathic nerve pain conditions.
Side effects.
Common ones are dizziness, drowsiness or fatigue, maybe some unsteadiness, ataxia, and sometimes weight gain. It's generally advised not to stop them abruptly, and dose adjustments are often needed in older adults or people with kidney problems.
Right. And the last way to boost GABA was decreasing its breakdown. Vigabatrin was the drug here.
Correct. Vigabatrin works by permanently inhibiting an enzyme called GABA transaminase. This enzyme is responsible for breaking down GABA inside cells.
So blocking the breakdown enzyme means more GABA builds up.
Exactly. Higher GABA levels enhance inhibition. It's used for partial seizures, sometimes particularly for infantile spasms, but it comes with a significant potential side effect.
Which is?
It can cause visual field defects, basically, losing parts of peripheral vision. And this can unfortunately be permanent in some cases, so it requires careful monitoring and is used quite cautiously.
Yeah, the lecture noted that comparison tiagabine might cause dizziness or concentration issues, but vigabatrin has that serious visual risk and isn't for people with a history of psychosis or hallucinations.
Right. It really highlights how even drugs aiming for the same general target boosting GABA can have very different safety profiles and uses.
Definitely. Okay, so we've walked through the main ways these drugs work. Now, shifting to the practical side, when do doctors actually decide to start treatment? Is it after the very first seizure?
Generally, no. A single isolated seizure doesn't automatically mean someone needs long-term medication. The usual guideline is to consider starting treatment after someone has had 2 or more unprovoked seizures, often within about a year or maybe 2.
Okay, 2 or more. And when they do start, do they usually jump to using multiple drugs?
No, the strong preference is almost always for monotherapy first, using just one single drug.
Why is that?
Mainly to minimize side effects and the potential for drug interactions, which obviously increase when you start combining medications. The goal is always to find the lowest effective dose of one drug that controls the seizures well without causing unacceptable side effects.
And if one drug doesn't work?
Then you might try switching to a different single drug. Using multiple drugs, polytherapy, is usually reserved for cases where seizures just aren't controlled adequately with monotherapy, what we call refractory epilepsy.
Makes sense. What about stopping medication? If someone's been seizure-free for a while, can they come off it?
That's a really important conversation to have. Yes, if someone has been completely seizure-free for a significant period, typically at least 2 years, then discussing the possibility of slowly tapering off medication can be appropriate.
Slowly being the key word.
Absolutely, never stop suddenly. But even after 2 or more years seizure-free, there's still a risk of recurrence when stopping meds. The estimates vary, but it's maybe in the range of 25 to 40% chance the seizures could come back.
So it's not guaranteed they'll stay seizure-free.
No, which means the decision to stop is very personal. It involves weighing the benefits of being off medication, avoiding side effects, cost, hassle against that risk of having seizures again, and what the consequences of that would be for the individual.
Right. Okay, the lecture also specifically discussed status epilepticus. You mentioned this earlier. Sounds very serious.
It absolutely is. It's a neurological emergency. Status epilepticus basically means either a seizure that goes on for too long, the traditional definition was over 30 minutes, but clinically we act much sooner, or when someone has repeated seizures back to back without fully regaining consciousness in between.
And why is it such an emergency?
Because prolonged continuous seizure activity can actually damage brain cells, potentially causing permanent injury or even death. So, stopping it quickly is critical. The current thinking is to start emergency treatment if a generalized tonic-clonic seizure lasts longer than 5 minutes or a focal seizure goes beyond 10 minutes. We don't wait for 30 minutes.
Okay, 5 minutes for tonic-clonic. What's the immediate treatment plan?
First line is usually a benzodiazepine given intravenously. Lorazepam or diazepam are the go-to drugs. If IV access isn't immediately available, sometimes midazolam can be given as an injection into the muscle.
And if that doesn't work?
If the seizure continues despite the benzodiazepine, then we move to second-line agents. Typically, this involves giving IV fosphenytoin or phenytoin. Intravenous phenobarbital is another option.
And if that still doesn't stop it?
Then it's called refractory status epilepticus, and things get very serious. Often this requires transferring the patient to an intensive care unit and using intravenous anesthetic drugs to induce a coma, essentially forcing the brain activity to quiet down while trying to figure out the underlying cause.
Wow, okay. Lastly, the lecture addressed using these drugs during pregnancy.
Yeah.
That must involve some really tough conditions.
It's a very delicate balance, yes. On one hand, having seizures during pregnancy can pose risks to both the mother, like falls or injuries, and potentially to the developing baby due to changes in oxygen supply or stress hormones.
So stopping meds isn't necessarily the safest option.
Often no. For many women with epilepsy, continuing medication during pregnancy is necessary to control seizures. The goal is to use the lowest possible effective dose of the safest possible drug.
Are some drugs considered riskier than others during pregnancy?
Yes, definitely. Some anti-epileptics have a clearly higher association with birth defects or developmental problems. Valproate is probably the most concerning in this regard. Phenobarbital and topiramate are also generally considered higher risk and avoided if possible, especially around conception and during the first trimester when organs are forming.
Are there safer alternatives?
Some drugs appear to carry a lower risk. Lamotrigine and levetiracetam are often cited as having among the lowest known risks based on current data, though no drug is considered completely risk-free. The choice is very individualized.
Anything else to consider with pregnancy?
One other point is that some of the older enzyme-inducing drugs like phenytoin, carbamazepine, phenobarbital can potentially interfere with vitamin K metabolism. This could lead to a risk of bleeding in the newborn right after birth.
How is that managed?
It's usually prevented quite effectively by giving the mother vitamin K supplements in the last few weeks of pregnancy and by giving the baby an injection of vitamin K routinely right after delivery.
Okay, that's a huge amount of ground we've covered. It really paints a picture of just how complex managing seizures is. So to kind of wrap up our deep dive, we've seen that seizures are these disruptions in the brain's electrical rhythms.
Right, these electrical storms. And the anticonvulsant drugs work through all these different mechanisms, blocking sodium or calcium channels, boosting GABA, trying to restore that normal rhythm.
And the choice of drug really depends on the specific type of seizure.
Yeah.
And it's always a balance between controlling the seizures and managing potential side effects.
Especially in situations like pregnancy or when dealing with emergencies like status epilepticus. It's highly personalized medicine.
Yeah, and I think the aha moments, for me at least, come from understanding how these different drugs target specific pathways. Seeing the connection between the type of seizure and the mechanism of the drug that treats it, it gives you a real glimpse into the brain's wiring.
Absolutely. It shows how we're trying to precisely intervene in these incredibly complex neurological processes. Understanding the difference between blocking a T-type calcium channel for absent seizures versus, say, enhancing GABA for broader control, it really highlights the sophisticated approach a pharmacology takes.
It does. So maybe a final thought for you, the listener, to chew on. When you consider just how intricate epilepsy is and the sheer variety of ways we try to treat it, what does that reveal about the brain itself? About its amazing ability to maintain balance most of the time, and the profound challenges we face when that delicate balance gets disrupted.
Yeah, it really underscores the ongoing research needed and how managing epilepsy often requires such a tailored individual approach. It's a constant effort to understand and restore that intricate balance.